Welcome to Dr. Amanda Clarke, Heart Health and Cardiology. Nobody warned you that the day you turned 50 your heart entered a completely different chapter of risk. Not a gradual shift. Not a slow drift toward greater vulnerability. A step change. A moment in your cardiovascular biology when the rules of the game changed in ways that most Americans are never told about clearly enough to actually do something about. The same heart that carried you through your 30s and your 40s, without major complaint, is now operating in an environment that is measurably, provably, scientifically different. The same habits that seemed fine at 40 are producing different consequences at 52. The same blood pressure reading that your doctor described as something to watch at 45 now carries a risk profile that is dramatically more urgent. And most Americans over 50 are going about their lives with a level of cardiovascular awareness that is calibrated for the person they were a decade ago, rather than the person their heart is dealing with right now. Here is the number from the most authoritative cardiovascular research, published in 2026, that should stop every American over 50 cold. A major study published in the New England Journal of Medicine analyzed more than 2 million people worldwide and found that men and women with none of the 5 major cardiovascular risk factors at age 50 lived more than a decade longer than those with all 5 risk factors. Women with none of the risk factors at 50 lived 14 and a half years longer and had more than 13 additional years free of cardiovascular disease. Men without the risk factors lived nearly 12 years longer. The single most powerful intervention for delaying death was quitting smoking in the mid-50s to age 60. The most powerful intervention for living without cardiovascular disease longer was controlling hypertension. These are not abstract projections about distant populations. They are the documented outcomes of real people whose cardiovascular risk at 50 determined in measurable specific terms how many healthy years they lived. And they are telling every American over 50 something that cannot be ignored. What you do about your cardiovascular health in the next 5 years is more consequential for the length and quality of your life than almost any other health decision you will make. By the time this video ends, you will understand exactly what changes in cardiovascular biology happen at the transition to 50 that elevate risk in ways most Americans are never explained. What the 5 risk factors are that determine whether you live a decade longer or shorter, and what your current status is on each of them. What the JACC Cardiovascular Statistics Report published in 2026 says about where most American adults over 50 currently stand on those risk factors, what the specific warning signs that most commonly appear in the 50 to 65 age group are, and why they are so frequently dismissed, and what the most evidence-based actions are that produce the greatest cardiovascular benefit, specifically for people in this age group. Stay with us until the very end because the final section of this video contains the single most surprising and most immediately actionable finding about cardiovascular risk in the over 50 population that the 2026 research has produced. Let us start with the biology, because understanding what actually changes at 50 changes everything about why this conversation matters so urgently for this specific age group rather than for Americans of any age. The cardiovascular changes that occur through the 5th decade of life are not the gradual accumulation of wear and tear that most people vaguely imagine when they think about aging. They are specific, identifiable, measurable biological shifts that interact with each other in ways that produce a cardiovascular risk environment substantially more dangerous than what existed at 40. The first change is arterial stiffening. The walls of your arteries are not rigid pipes. They are living tissue containing elastic fibers that allow them to expand and contract with each heartbeat, absorbing the pressure of blood flow and smoothing it into a steady stream that your organs can manage. With each decade of life, those elastic fibers progressively stiffen and are gradually replaced by collagen, which is far less flexible. By the time most Americans reach their early 50s, this stiffening has reached a point where it meaningfully affects the way blood pressure behaves throughout the body. Stiffer arteries cannot absorb the pressure of each heartbeat as effectively. Systolic blood pressure rises. The heart must work harder to push blood through less compliant vessels. And the risk of both heart attack and stroke increases as a direct result of the mechanical changes in the arterial walls that have been accumulating since your mid-30s. The second change involves hormones. For women, the transition through perimenopause and menopause produces a dramatic shift in the hormonal environment that had been protecting the cardiovascular system throughout the reproductive years. Estrogen has multiple cardioprotective effects. including maintaining arterial flexibility, supporting favorable cholesterol balance, reducing inflammation in vessel walls, and promoting healthy blood vessel function. As estrogen levels decline through the menopausal transition, those protections diminish. LDL cholesterol tends to rise. HDL cholesterol may fall. Blood pressure often increases, and the rate of atherosclerotic plaque accumulation accelerates in ways that can produce in just 5 to 10 years the cardiovascular disease burden that would have taken decades longer to develop in the presence of adequate estrogen. For men, the testosterone decline that occurs through the 50s produces its own cardiovascular consequences, including increased abdominal fat accumulation, reduced insulin sensitivity, and changes in inflammatory markers that all trend in an unfavorable cardiovascular direction. The third change is metabolic. Insulin resistance, the condition in which cells become less responsive to insulin and require higher levels of the hormone to manage blood glucose, becomes significantly more prevalent after 50. The JACC Cardiovascular Statistics report published in 2026 found that type 2 diabetes and prediabetes now impacts nearly half of all adults in the United States, and that the aging baby boomer population reaching the age of peak cardiovascular risk is one of the primary drivers of the current crisis in cardiovascular mortality from conditions like heart failure, arrhythmia, and hypertensive heart disease. Deaths from other types of heart disease, including arrhythmia, heart failure, and hypertensive heart disease, increased by 81% in the United States over the past several decades, according to a study published in the Journal of the American Heart Association in June 2025. Not coronary heart disease deaths, which have actually declined with improved treatment. The other types. The ones that kill people who did not think they were at serious cardiac risk. Now here is what most people never find out about cardiovascular risk after 50. The 5 risk factors that the New England Journal of Medicine study identified as determining whether someone at 50 lives a decade longer or shorter are not exotic or unusual conditions requiring specialized testing to identify. They are high blood pressure, high cholesterol, diabetes, obesity, and smoking. These are the 5 most common, most measurable, and most modifiable cardiovascular risk factors in American medicine. And the research says that every single one of them matters more after 50 than it did at any earlier point in life, because the biological environment in which they are operating has changed in the ways we just described. The same blood pressure that your doctor said was something to keep an eye on at 45 is doing a different quality of damage to arteries that have been stiffening for 5 additional years. The same cholesterol reading that seemed borderline manageable at 48 is operating in blood vessels where estrogen or testosterone are no longer providing the protection they once did. Let me tell you about Margaret. She was 53 years old, a high school librarian from Virginia, who had been managing what she described as pretty good health for her age. Her blood pressure had been in the elevated range for 3 years, consistently around 135/85. Her LDL was 122. Her doctor had told her both numbers were something to watch and recommended lifestyle changes. Margaret had made some changes. She ate better than she had in her 40s. She walked most days, and she felt fine. The problem was that Margaret's cardiovascular system was no longer operating in the environment of her 40s. Estrogen had been declining for 2 years. Her arterial walls were stiffening at a rate that the research shows accelerates significantly through the menopausal transition, and the blood pressure of 135/85, that had been a yellow flag at 48, was now producing a different level of daily arterial stress in a cardiovascular system that was simultaneously losing its hormonal protection. When Margaret developed atrial fibrillation at 54, the irregular heart rhythm that the JACC 2026 statistics identify as one of the fastest-growing cardiovascular conditions in Americans over 50, her cardiologist told her directly that her blood pressure had been doing damage that she could not feel, and that the hormonal transition had accelerated a process that her borderline numbers had been enabling for years. And this is where it gets really serious. Because the cardiovascular conditions that are growing fastest in Americans over 50 are not the ones most people think of first when they think about heart disease. Coronary heart disease, the blockage of the major heart arteries that causes the classic heart attack, has actually seen declining death rates with improved treatment and intervention. But other forms of cardiovascular disease are rising sharply. Deaths from arrhythmias, particularly atrial fibrillation, have increased significantly. Heart failure, the condition in which the heart cannot pump blood efficiently enough to meet the body's needs, is now the most common reason for hospitalization in Americans over 65. Hypertensive heart disease, the structural damage to the heart that results from years of elevated blood pressure, is killing more Americans than it was 2 decades ago, despite better medications. These are the conditions that are growing in the population that most needs to understand them, and they are growing precisely because the cardiovascular risk factors that drive them are most prevalent after 50 and most frequently undertreated in the years when intervention would be most effective. But here is something your doctor may not have had time to explain about the over 50 cardiovascular risk picture. The single most powerful protective action available to people in this age group is not a new medication or a revolutionary treatment. It is the identification and aggressive management of existing risk factors with a level of urgency that the transition to 50 specifically demands. The New England Journal of Medicine study was emphatic on this point. Controlling hypertension was identified as the most powerful intervention for extending years free of cardiovascular disease. Not avoiding hypertension by being young and healthy, controlling it, managing it aggressively in the years when the arterial damage it causes is accelerating most rapidly. An American over 50 with controlled blood pressure is in a dramatically different cardiovascular position than an American over 50 with uncontrolled or inadequately controlled blood pressure. And the gap between those two positions, in terms of years of healthy life, is not measured in months. It is measured in years. Possibly in that decade or more that the research documents so specifically. Now let me tell you about Thomas. He was 58 years old, a marketing executive from Ohio, who described himself as someone who had always meant to take better care of himself, but had never quite made it the priority it deserved to be. His blood pressure was 148/92. His LDL was 161. He had never smoked. He was somewhat overweight, but not dramatically so. He exercised occasionally. He felt fine. His annual physical happened every 2 years rather than every year because he was busy and felt fine and saw no urgent reason to go more frequently. When his cardiologist eventually reviewed a full cardiovascular risk assessment, Thomas discovered that his 10-year risk of a major cardiovascular event was calculated at 16%, 1 in 6. In the next decade, not because he had done something dramatically wrong, because the combination of elevated blood pressure, elevated LDL, advancing age, and male sex, in the context of the arterial stiffening and metabolic changes of his late 50s, had combined to produce a risk profile that was far more urgent than how he felt suggested. Thomas began aggressive management of both his blood pressure and his cholesterol, with a combination of medication and lifestyle changes. His cardiologist told him directly that the next 5 years of management were the most consequential years of his cardiovascular life, that the choices made between now and 63 would determine his cardiovascular health at 70, at 75, and beyond. Now here is something the research actually shows that most people find genuinely surprising and genuinely hopeful about cardiovascular risk in the over 50 population. It is never too late for meaningful intervention. The research is clear and specific on this point. Quitting smoking in the mid-50s to age 60 was identified in the New England Journal of Medicine study as the intervention that had the most impact on delaying death. Not quitting at 30, not quitting at 45. Quitting in the mid-50s to 60 still produced the greatest single intervention effect on longevity. Blood pressure control initiated at 55 produces measurable reductions in stroke and heart failure risk within years of beginning treatment. LDL reduction started at any age produces cardiovascular benefit, and the research on physical activity and cardiovascular outcomes is consistent in showing that sedentary adults who begin regular moderate exercise in their 50s experience meaningful reductions in cardiovascular risk that are visible within months of beginning a consistent program. The cardiovascular system after 50 is not a fixed trajectory toward inevitable decline. It is a system that responds to the conditions it operates in. Improve those conditions and the system responds. The biological changes of the 5th decade and beyond are real and they are consequential. But they are not destiny. They are a context within which the choices that are made now about blood pressure, about cholesterol, about physical activity, about smoking, about weight, produce more concentrated consequences than at any earlier point in life. The urgency is higher. The stakes are higher. And the potential benefit of getting it right is more clearly and specifically documented than at any earlier point in the cardiovascular lifespan. Let us talk about what specifically getting it right looks like for someone in the 50 to 65 age group, because the practical application of everything we have discussed needs to translate into specific actions rather than general intentions. The first and most urgent priority is knowing your numbers, all of them: blood pressure, LDL and HDL cholesterol, fasting blood glucose, body weight, and for many people in this age group, a 10-year cardiovascular risk score calculated by a cardiologist or primary care physician, who inputs all of those numbers into the validated risk calculation tools that the most current guidelines recommend. That number, the 10-year risk calculation, gives you and your doctor a specific, evidence-based target for how aggressively to treat each risk factor. Someone at 5% 10-year risk needs different intensity of intervention than someone at 15% 10-year risk. And most Americans over 50 do not know which category they are in because they have not had the conversation that produces that number. The second priority is ensuring that known risk factors are being managed with the level of intensity that the 2026 guidelines recommend for the over 50 age group. Specifically, the guidelines have moved in the direction of more aggressive treatment targets in recent years, particularly for LDL cholesterol and blood pressure, reflecting the accumulated evidence that tighter control of these factors in the over 50 population produces dramatically better cardiovascular outcomes than the more permissive targets of previous generations of guidelines. If you have been told your numbers are okay and your last cardiovascular assessment was more than 2 years ago, it is worth asking your doctor to review whether your current treatment targets reflect the most current guideline recommendations for your age and risk profile. The third priority is specific to women in this age group and is one of the most important conversations in all of contemporary cardiology. The cardiovascular implications of the menopausal transition deserve explicit discussion with a knowledgeable healthcare provider. The question of whether hormone therapy is appropriate and safe for a given individual is genuinely complex and genuinely individual, but the cardiovascular implications of the hormonal changes of the menopausal transition are real and documented, and every woman in her early 50s should be having an explicit conversation with her doctor about how those changes are affecting her cardiovascular risk profile, and what, if anything, should be done about them. That conversation happens far less often than the research says it should. And the fourth priority applies to every American over 50, regardless of sex, regardless of current health status, regardless of how fine they feel right now. Annual cardiovascular risk review with a healthcare provider. Not every 2 years. Not when something feels wrong, every year. Because the changes in cardiovascular biology that occur through the 50s happen on a timeline that makes annual reassessment the minimum appropriate frequency for monitoring a situation that is actively evolving. Feeling fine after 50 is not the same as being fine after 50. That distinction, grounded in the biology and the research we have discussed today, is the most important thing every American in this age group can understand. The heart does not always announce its distress. The arteries do not send pain signals as they stiffen. The plaque does not create symptoms as it builds. The risk accumulates silently, and the time to act on it is now, before the symptom that would have prompted the appointment, before the event that would have changed everything. Now, if this video gave you a genuinely clearer and more complete understanding of why cardiovascular risk changes so significantly after 50, what the research says about what makes the difference between a decade more of healthy life or a decade less, and what the specific actions are that produce the greatest cardiovascular benefit in this age group, subscribe to Dr. Amanda Clarke, and turn on notifications so you never miss a video that matters for your health. And drop a comment below answering this question honestly. Are you over 50, and do you know your current 10-year cardiovascular risk score? And if not, is this video the reason you are going to find out? Every comment matters, and your honest answers help us understand what this community needs most.